brand new heart conditions in a young person, carbon monoxide poisoning, and a swollen knee that turned into something that the parents never expected. I had a crazy week this week in the emergency room. I can't wait to tell you about it. My name is Dr. Eli Fryman, and I am a board-certified pediatric emergency medicine specialist. I work in a local ER, and I see over 3,000 patients a year. And in these videos, I like to talk about my last week in the ER. So we're going to dive right in. It's amazing to me that even though I see thousands of patients a year in the emergency room, and I have for over 6 years at this point, I still every week see something and diagnose something in the ER that I've never done before. I want to talk about the first patient that I saw this week, a 20-year-old young man who came into the emergency room with palpitations. For those of you who don't know, palpitations is a medical term for this heart racing, heart fluttering symptom. When you feel your heartbeat in your chest, maybe it's too fast, maybe it's uncomfortable, maybe it just feels different than you've felt it before. It's a really common reason why people come into the emergency room. This patient had never really had palpitations before, and he's in college. So he was going about his day when all of a sudden he felt that his heart didn't feel quite right. It wasn't quite too fast, but it felt like it wasn't beating the way that it should. And that was really the only way he could describe it. He just said it felt weird, like he hadn't felt it before. So he went to his student health services, which was the right first place to go. Thank you for doing that first. And the doctor evaluated him there and just said, "You need to go to the ER." And that's all they told him. All they know, he comes into the ER, and I asked him why he's there. And he said, "I don't know. The doc at Student Health Services just said, you need to go to the ER. You have a heart condition." I'll be honest, I was a little skeptical, right? This is a healthy 20-year-old guy who's never had any heart problems before. All of that means that his risk factors for heart disease, way, like basement low. So when he gets referred into the emergency room because he got a new heart condition, I might have rolled my eyes a little bit. But it's also important to acknowledge when we're wrong and maybe when we come to conclusions a little too quickly, because what this young man did is he reached into his pocket and pulled out some medical records that Student Health had gave him and handed it to me. And what I did is I opened it up and looked at it and my eyes went wide. And I said, okay, we have some testing to do. This young man, actually, when I dove into the history a little bit, said that he thinks he might have been getting palpitations on and off for months, but he never really felt or did much about it. He hadn't seen a doctor for it. He said they typically came on for maybe a couple seconds at a time, no more than a minute. They resolved on their own. He didn't think they were caused by anything in particular. He wasn't sick. It wasn't alcohol. He wasn't drinking coffee. They just sort of happened sometimes. But this time, today, when they happened, it lasted longer and was more uncomfortable than it had been previously. The first thing that I noticed about him when I evaluated him is that he looked really good. And what I mean by that, not that he was handsome, not commenting on his looks, I mean that clinically he didn't look sick. And when someone comes into the emergency room, the first thing we do as ER doctors is just look at the patient and make a determination. Are they sick? Are they not sick? And when we say sick or not sick, we mean, does this patient look like they're in the process of actively dying? Or does this patient look like they are maybe not feeling great, maybe have some symptoms going on, but overall they look like, at least from the door, they're going to be okay. And this patient definitely looked like he was going to be okay. He wasn't gray, he was awake, he was talking, he had good muscle tone, and frankly, his vital signs were normal. One of the first things we think about with heart conditions is the heart too fast? Is it too slow? How's the blood pressure? How's the oxygen? Is the patient febrile? Do they have a fever? And this patient's vital signs were normal, which frankly is a great place to start. And what I did was I took a look in his mouth, made sure he was hydrated, took a look at his neck, listened to his lungs. But then when I listened to his heart, what was interesting about it is that the heart rhythm wasn't right. It was irregular. And what I mean by that is when you listen to a patient's heart, the heart rhythm should have a very regular, almost metronomic lub-dub, lub-dub, lub-dub. But this patient's heartbeat was chaotic. It was irregular. That was really surprising to me because the most common cause of what we call an irregularly irregular rhythm in the emergency room is something called atrial fibrillation, or AFib. While AFib in and of itself is not that uncommon a diagnosis, now I'm not an old people, aka anyone over 22 doctor, but in general, I'm pretty sure, and someone in the comments correct me on this, probably a third of people over their lifetime develop AFib. Give or take, I don't know, 30, 40%, who knows? someone other than me. But not when you're 22, right? I think the most common incidence of atrial fibrillation is over the age of 55, give or take. This patient's 20. He's 20, right? And he comes into the emergency room in what I think is new-onset atrial fibrillation. But why? He doesn't have any history of heart disease. He doesn't have any history of anything else going on. And he just said he was having these palpitations for months, which made me realize, oh gosh, he's probably been an AFib for months, which is really weird, right? It's weird for a 20-year-old to come into the emergency room with new-onset atrial fibrillation. And I, to be honest, have literally never seen that before. I've seen AFib, not in a 20-year-old. So we get the electrocardiogram, stickers on the chest to look at the heart rhythm, and the kid's in AFib. And I have no idea why. No idea why. We do the blood work. We get blood tests, electrolytes, liver function tests, troponin to make sure it's not heart injury. And it's all normal. His electrolytes look great. Potassium, magnesium, all that look great. Blood counts look great. Troponin is great. Pro-BNP is normal. We get an x-ray because I'm an ER doctor, so I love x-rays. So we get x-rays. And it was normal. And I have no idea why this guy's an AFib. AFib is really common and is typically what's considered to be a stable heart rhythm. Patients can be symptomatic with atrial fibrillation. You can have those palpitations, of course. You can also have dizziness, fatigue, shortness of breath, especially with activity. But in general, the rhythm itself is not considered to be dangerous. In fact, many people are in AFib for years and years at a time. First of all, what is atrial fibrillation? Your heart has 4 chambers, 2 pumping chambers, the right ventricle, the left ventricle, and 2 antechambers, the right atrium and the left atrium. And atria or atrial fibrillation occurs when those atria start beating erratically or chaotically. And instead of this sort of coordinated squeeze motion, they just sort of wiggle or vibrate, or in medical terms, fibrillate, which means ineffective pumping of blood into the ventricles. Thankfully, the ventricles are still able to do their job for the most part, and blood makes its way in and out of the heart for the most part effectively. But you can imagine that if the atria, those antechambers, are not pumping effectively, the heart loses some of its pumping efficiency, and you get this irregular rhythm as the electricity is not moving through the heart in a coordinated manner like it did before. Patients with atrial fibrillation, for the most part, do okay. It's a stable rhythm, meaning that you can be in atrial fibrillation for days, weeks, months, years at a time and be safe. Now, that doesn't mean you might not be symptomatic. Patients with AFib often have palpitations, dizziness, fatigue, might get short of breath with exercise or exertion. But for the most part, it's not considered in and of itself to be a dangerous rhythm. But there are 2 things about AFib that we worry about. One is something called a rapid ventricular response, when the atria beating in the chaotic rhythm start causing the ventricles to beat too quickly. The other concern is that while these atria are fibrillating and not beating effectively, blood can sort of swirl within the atria rather than getting pumped effectively out of it into the ventricles. Blood does what blood does, and it can clot. And what you really don't want is to have blood clots in your heart. It can get pumped to your body, and it can cause blood clots in your lungs, in your organs, in your brain, and patients can stroke. So patients who have AFib are often put on anticoagulators or blood thinners in order to help prevent blood clots, because that's one of the scariest things about AFib is, are you going to throw a clot somewhere in your body and stroke out at any time? This 20-year-old guy, heart problem, you call a heart doctor. And I'll never forget this. The cardiologist on the phone asked me 3 times how old this kid was. I told her, I said, I have a 20-year-old male who's coming in with new-onset AFib. And she stopped me and she said, wait, how old? I said, 20. She goes, one more time. I said, 20, 20. She goes, are you sure? Yeah, I'm positive. He's 20. And she goes, I've never seen that before. A cardiologist told me she's never seen AFib in a patient that young before. I said, hey, me too. We're on the same page now. Thank you. She was very nice. She was just surprised. And what was interesting is we ended up referring him to her clinic, and she ended up seeing him in clinic with his mom a little bit later. And what came out that he didn't know when I saw him in the ER alone is that his mom had AFib and his uncle had AFib, and they had other proximate family members that have AFib. So our best guess is that this patient actually has a genetic mutation that might predispose to AFib at a young age. Never seen that before. This patient will follow up with cardiology and they'll do what they do, but hey, it is always an interesting day in the emergency room when I see a new case I haven't seen before. So let's talk about the second case, really interesting. We had a 18-year-old man who was working at a restaurant who came into the emergency room with headache, dizziness, trouble breathing, chest pain, and just seemed a little out of it. His symptoms had started while he was at work. He had a normal morning. He had gone to work. He had been feeling well. He hadn't been sick, no fevers, no coughs, no anything like that. But while he was at work, he started to develop these sort of vague symptoms: headache, dizziness, visual disturbance, a little bit of nausea, this chest pain. And what was weird about it is that he didn't think he was the only one who felt sick. He looked around and he thought that some of his other colleagues were starting to feel a little bit sick too. So called an ambulance and came into the emergency room. And the first question we asked him, where do you work? What do you do? What was happening? And he works in an industrial kitchen. So right off the bat, we had a pretty good idea about what was going to go on with this patient. And we put the oxygen meter on his finger and it was reading 100%. So you might think, aha, this patient doesn't have any issue with their oxygen transport to their body. And you would be wrong, because this patient ended up having carbon monoxide poisoning. Now, what is carbon monoxide? Carbon monoxide is a colorless, odorless gas that is one carbon molecule and one oxygen molecule, unlike carbon dioxide, which is one carbon molecule and two oxygen molecules. And you typically see it when things are being combusted, like, for example, an industrial kitchen. And the issue with carbon monoxide, and the reason why it's so dangerous, is because, boy, does it love your red blood cells. In order for your red blood cells to transport oxygen to the rest of your body, they have a molecule you've probably heard of called hemoglobin. And oxygen binds to the hemoglobin and gets transported throughout your body and then gets released to whatever tissues in your body need it. The issue with carbon monoxide is carbon monoxide loves that hemoglobin even more than your oxygen does. So when you breathe in carbon monoxide, the carbon monoxide gets into your lungs, it gets into your blood, and it holds on to that hemoglobin and it will not let go. It hogs it and it doesn't share, right? It's like my 3-year-old toddlers. It hogs it and it doesn't share. What happens is the oxygen can't bind the hemoglobin. And when it can't bind the hemoglobin, it can't be transported to the rest of your body. And it feels like you're being deprived of oxygen, because frankly, you are being deprived of oxygen. Even if you're breathing in enough oxygen into your body can't use it. It can't transport it. In the emergency room, we see carbon monoxide poisoning when patients are in the right environment to be exposed to carbon monoxide. You'll often see it with poor heating appliances. So you might see boilers or furnaces that are malfunctioning. You might see it when people are using combustion appliances like gas or wood stoves, fireplaces, space heaters are a really common one. You might see it with car exhaust. You might see it when patients are in industrial places like kitchens. You might see it with occupational hazards like firefighters. And when patients have a good story for likely being exposed to carbon monoxide because they work in an industrial kitchen and everyone else is sick, or they're a firefighter who was just in a burning building, or it was really cold and they turned on their space heater in a room with no ventilation, and then they come into the ER with typical symptoms: headache, dizziness, nausea, visual disturbances, sometimes even altered mental status, meaning they were confused or obtunded, then it's really important to diagnose carbon monoxide poisoning early. Because as you can imagine, a molecule that binds your hemoglobin and makes it difficult for your body to utilize oxygen is bad news. So when patients come into the emergency room, the first thing that we do, we slap them on a 100% oxygen, meaning that we'll take what's called a non-rebreather, we'll hook it up to an oxygen tank or an oxygen tube on the wall, and we'll put it right on their face and blow 100% oxygen so they breathe it in, literally trying to displace the carbon monoxide from their hemoglobin by force. You just flood your blood with as much oxygen as possible, hoping that it forces the carbon monoxide off those hemoglobin molecules so the oxygen can take its place and your body, frankly, can survive. The next thing that we do after that is we send off blood tests to try to determine the level of something called carboxyhemoglobin, or how much of your hemoglobin in your body is bound to carbon monoxide. Typically, levels are below 1 to 2%. If you smoke, actually, your levels could be chronically a little bit more elevated. But as those levels get higher and higher and higher, the risk of what's called cardiovascular collapse, as your body just falls apart with lack of oxygen, gets higher and higher and higher. When you get to the 20, 25, 30% range, it becomes critically dangerous. And these patients often need to be transported to what's called a hyperbaric oxygen chamber, which is exactly what it sounds like. When you can increase the pressure of oxygen in the atmosphere to even force it into a patient's lungs and blood harder in order to try to displace the carbon monoxide, which requires transport to a specialty hospital with a specialty setup in order to make sure that this patient literally does not die from the carbon monoxide that they've inhaled. In this patient's case, his carboxyhemoglobin levels came back just above 20%. Thankfully, by the time the level of carboxyhemoglobin had come back from the lab, he had already been on that inhaled non-rebreather at 100% supplemental oxygen for about 15 to 20 minutes at that point, and he was feeling better. So instead of transporting him to a hyperbaric oxygen chamber, what we did is we kept him on the non-rebreather for about another hour or two until his symptoms resolved. And what we did at that point is we resent the carboxyhemoglobin level from his blood, and it had dropped all the way to 2%. So we sent him home. And it turned out that there ended up being an occupational exposure to that whole kitchen. That entire restaurant had been potentially exposed to carbon monoxide. And I think we ended up seeing 10 or 15 patients that day with carbon monoxide poisoning, all from that one kitchen exposure. All right, lastly, I had an 8-year-old patient who came into the emergency room with a swollen knee. That was the story. He said that over the last couple days, he had noticed that his right knee had been bothering him. It had been swollen, it had started to hurt, and the more he walked on it or the more he ran on it, it got worse. He didn't remember injuring it. He didn't fall. He wasn't in a car accident, anything like that. He had no prior injuries to the knee. He just knew that sort of out of nowhere, it had become swollen. And mom was worried and brought him into the emergency room because today it had gotten a little red and he started developing a little bit of a fever. When I walked into this room, this patient was sitting on a stretcher. He was sitting up, he's 8 years old, sitting up on a stretcher with his leg out. And you could tell right from the door, his right knee was swollen. You didn't need a microscope. Anyone could do it. His right knee was about the size of multiple grapefruits, all things considered, and his left knee looked totally normal. So I could tell you right off the bat, yes, that knee was swollen. Now, of course, the question is, why, right? And that's my job to figure out. I go through the questions. Have you been sick at all recently? No, not until today. No fevers until today. Have you had any cold symptoms, any car accidents, any history of fractures or knee injuries or anything like that? No, 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 no. To examine the patient, what I did is you always examine the major joints, not only that are affected, but above and below. So in this case, I actually started with his hip because I wanted to make sure that while clearly his knee was infected or affected, we'll get there, I wanted to make sure his hip also wasn't affected. So I made sure that his hip ranged in all directions without pain, which it did. And then I went down to his ankle and made sure that his ankle ranged in all directions without pain, which it did. He also had good blood flow and good nerve function all the way down to his toes. So I knew that this was likely an isolated knee issue. Okay, good place to start. The next thing that I did is I got an ultrasound probe, and I love using ultrasound for this. It's one of my favorite things to do in the emergency room. I got an ultrasound probe, brought it to the bedside, and put it right on his knee. And what we saw is that his knee was full of fluid, which, given how it looked, isn't surprising. But it did look like fluid that wasn't blood. From here is when we need to start considering, okay, what could this be? Obviously, we're worried about an infection of the knee. I've talked about in my other videos, infection's a broad category. He could have a viral infection of his knee. He could have something called a post-viral infection of his knee or post-viral arthritis or toxic synovitis. He could have a bacterial infection of his knee. We call that septic arthritis. You can even have Lyme disease in your knee. And the part of the country I live in, that's actually pretty common. So all three of those things were in my mind when we talked about, okay, what do we need to do to figure out how to treat this kid? Step one, X-ray. While I don't think that that leg is broken, boy, does it look bad if we end up trying to diagnose this kid with an infection and his femur's broken, and that's why his knee's swollen. We always start with an X-ray, and as you might expect, the X-ray looked okay. There was no fracture. There was what they call an effusion or clear fluid buildup around the knee, but other than that, everything looked okay. Great. Box one, checked. Box two, blood work. After we do the X-ray, we need to help us understand what is the likelihood that this patient has a bacterial infection or maybe even Lyme disease in his knee. So what we do is we send off blood counts, inflammatory markers, and a blood culture. And all of that data together helps us sort of risk stratify, meaning that we look at all the data in its totality and decide, are enough of these numbers elevated that we're worried about a bacteria and we need to do something about it? Or are the numbers low enough where we think we can watch and wait for a little while to sort of see what happens? In his case, his numbers were elevated, and his ESR, his CRP, his white blood cell count, his neutrophil percent, all elevated. So we knew that we were potentially worried about what's called a septic joint, or there might be bacteria in that knee. The issue with septic arthritis is if it's untreated, it can be rapidly destructive. Like any bacterial infections, especially any deep or internal bacterial infections, the issue with not treating them and not treating them early could be devastating. So especially in a young growing child, not treating septic arthritis of the knee could lead to destruction of the bones, the soft tissues, and could really hamper growth and development. So we knew this is something we needed to go after. In order to go after septic arthritis, or in order to diagnose a knee infection, you actually need the fluid in the knee itself. So we had to do something called a knee arthrocentesis, meaning that we literally had to numb up this child's knee and put a large gauge needle, in this case I think it was an 18 gauge needle, into the side of the knee, through the skin, into the fluid, and draw out that fluid to send to the lab for evaluation. In this case, I think we got a full ounce of fluid out of his knee. Actually, we probably could have gotten more, but by the time we got to 30 mLs, we knew that that was going to be enough for our diagnostics, and we stopped so the child could be done with the procedure. So we sent it off to the lab, and when we evaluate septic arthritis in the emergency room, we're looking for two things. We're looking for, are there any bacteria in the fluid, which is sort of a giveaway, it's bacterial septic arthritis. And what is the white blood cell count in that fluid? Well, how many nucleated white blood cells are there in that fluid? Because that gives us a hint that there might be some kind of infection that needs treating. Any blood count, any nucleated blood count above 20,000, 50,000, right? And somewhere in that area, we start to get nervous. If it's 5,000 or less, 7,000 or less, 800 or less, okay, fine, go home. But if you're above 20,000, certainly if you're above 50,000, we start to worry that, okay, there might be an infection here. And this child's blood count in the nucleated blood cell count in their knee fluid was 144,000, which is way too high. So I had to tell the parents that we were worried enough about a bacterial infection in the kid's knee that we had to transport them to a tertiary care hospital for an orthopedic surgeon to operate on this child. Because the way to protect a knee from a septic arthritis is you literally have to wash it out, meaning that this child was transferred to a tertiary care hospital. They were put under anesthesia, and in an operating room, the knee joint was opened up and it was washed out by a surgeon in order to make sure that if there was any infection in there, it's gone. And that's exactly what happened to this kid. He was transported, he was operated on, the knee was washed out, he was admitted to the hospital on antibiotics. And no joke, 2 days later, his Lyme test came back positive. No bacteria ended up growing from his knee, but his Lyme test showed that he had what's called Lyme arthritis of the knee, which is a known, uncommon, but not unheard of complication of Lyme disease, particularly in endemic areas. What's interesting about Lyme disease is that these secondary Lyme cases can occur if a child never knew they had a tick bite or never knew that they had primary Lyme disease in the first place. And if a child ends up developing arthritis from Lyme disease, 90% of the time, it is in one knee. So this was actually a really common presentation of an uncommon problem. While technically you can see Lyme arthritis all year round, it is more prevalent in the warmer months when children get Lyme disease to begin with. And thankfully, it's very treatable. You treat it with the same medicine that you treat regular Lyme disease with, doxycycline, if the patient is old enough. Otherwise, you can use some form of penicillin in consultation with a pediatric infectious disease doctor. So this patient was put on a couple weeks of doxycycline and has done well and is basically back to activity at this point. There you go. Another weird week for me in the emergency room. We had a common presentation of an uncommon problem in Lyme arthritis in this young child who never knew they had a tick bite to begin with. We had a young man brought into the emergency room with classic carbon monoxide poisoning from an industrial kitchen leak. And then I diagnosed a heart condition in a 20-year-old that I'd literally never seen at that age before. So I guess just another week at the office, and thanks for listening. I'll see you again real soon.